So we are going to talk about articulators. So what do you so we are going to talk about articulators. So what you need to understand at the outset is that in the condyle, when you have the condyle moving into the glenoid fossa, it is moving in the S-shaped curve. But in an articulator, you have a straight line path, right? That is why an articulator cannot simulate the entire, the condyle and glenoid fossa relationship in a 100% accurate manner. Now, coming on to the classification of articulators, you get a lot of questions from that. Based on the theories of occlusion, you have Bonville theory, conical theory, and spherical theory, right? The spherical was given by Monson. Conical is an example of Hall articulator. With Bonville, you have the Bonville's triangular theory, wherein you have 4 inches as one of the sides, each side of your Bonville triangle, right? When you talk about the conical theory, they say that it moves as if it is at an angle of 45 degrees, right? The cone is at an angle of 45 degrees. Now, this is one of the most basic classification of articulators. Coming on to the type of records, what kind of records can this articulator accept? You have articulators with interocclusal records and you have graphic records, right? Following this, you have the classification based on the ability to simulate movements. Very, very important classification. Class 1, only vertical movement is possible, right? The examples are your slab articulators, barn, door, hinge articulators. They come under class 1. The class 2 articulators have both horizontal and vertical, but they do not accept your phase bow transfer, right? Like your mean value articulators, Monson articulator, Hall articulator, House articulators, right? The type 3 or the class 3 is horizontal and vertical, plus it also accepts your phase bow transfers, right? You have an example of Hanau H2, Bergstrom articulator, Panadent articulator, True Bite articulator. All these come under the category of class 3. And class 4 are those articulators which accept 3D registrations, right? All the 3 dimensions can be recorded in a class 4 articulator like TMJ articulator or Stuart Nathoscope, right? So these are the articulators class 4 most commonly used in full mouth cases. Then you have articulators based on adjustability, right? They are your non-adjustable articulators, semi-adjustable articulators, and fully adjustable articulators. Non-adjustable are the ones which we use, like you have your hinge articulator, mean value articulators. Semi, you have your Hanau and whip mix articulator, and fully adjustable you have Stuart articulator or Granger simulator, right? Now the semi-adjustable articulators can be again classified into an Archon type and a non-Archon type. Archon is the one which is same as your mouth. That means the condylar part will be in the lower member and the upper member will have the articulating fossa, right? And non-archon is exactly the opposite of that. So majorly what you use is a non-archon articulator. So you don't get a lot of questions from articulators, but most of them are pretty straightforward the way we have seen it here. Another important topic is your teeth selection, right? The questions majorly come in from dentogenic concept. Who gave this concept? Frush and Fisher. Do not confuse with Fish. Fish gave the concept of neutral zone, right? Do not get confused. So dentogenic concept is also called as SPA factor or SPA concept, wherein S stands for sex, personality, and age, right? So these are important criteria when you do your teeth selection. For the posteriors, you have to understand that you have cusp teeth, you have your cuspless teeth, and you have some special forms. So in the cusp teeth, you have anatomical teeth and semi-anatomical teeth. So anatomical teeth are 33 degrees, and also there is one category of 30 degrees called as PT teeth, Pilkington Turner tooth at 30 degrees. Semi-anatomic can be 20 degrees or 10 degrees. 10 degrees are called as anatoline teeth. Right? So this is the major classification when you talk about posterior uh, teeth selection. Why 33 degree is considered as anatomic? Because 33 degrees is what you have, as your condylar guidance. Most commonly, the condylar guidance is 33 degrees. You will see an average of a lot of patients that comes down to 30 to 33 degrees. That is why the anatomic teeth range also ranges from 30 to 33 degrees. A very important question coming up from denture adhesives. Now, what are denture adhesives? They are majorly formed by CMC, carboxyl methyl cellulose, right? What is the mode of action of a denture adhesive? It swells when it comes in contact with saliva or water. As soon as it comes in contact, it swells up and fills in the space between the denture base and the tissue. That is how a denture adhesive acts. A few important questions coming up from sequelae of denture wearing. Not a lot of questions come in from sequelae, but there are few very typical questions. Denture stomatitis. They will give you cases. They will give you a case presentation as to how the patient approached after wearing the denture. They will give you a set of problems. With that set of problems, you need to diagnose what is the sequelae that the patient is suffering from. So denture stomatitis basically means sore mouth. So you have type 1, which is mainly trauma induced. Type 2, which is erythematous and diffuse, right? Type 1 is pinpoint. Type 2 is diffused. And type 3 is granular, right? So type 3 is a dangerous one, which is the granular denture stomatitis. Just something similar to a denture stomatitis is called CADS, Candida associated denture stomatitis. You will find mycelia there. Angular cheilitis, commonly present in Candida cases. Angular cheilitis. Another important question comes up from Epulis fissuratum, right? This is also called as denture irritation hyperplasia, right? When you get this question, do not confuse it with denture stomatitis, right? This is denture irritation hyperplasia, mostly caused due to unstable dentures, right? Then you have something which is called as burning mouth syndrome. No visible change in appearance. That is the most classical feature, that the patient is going to complain you of burning mouth majorly due to allergic reactions from the denture, or sometimes if the ridge is extremely resorbed, you have mental foramen lying on the crest of the ridge, you have pressure from the denture, and that is going to cause burning mouth syndrome, right? So these are a few important questions coming up from sequelae. There is one more thing which is called as inflammatory papillary hyperplasia, right? This is a benign lesion. Nodules are present around 2 millimeter size and mainly present in the location of hard palate, right? Next, we are going to talk about relining and rebasing, right? When you have to do relining and rebasing, when the denture has altered the tissue, or because of any systemic cause, the tissues have already got altered, like in cases of diabetes, etc., you will have to do relining and rebasing, right? Relining is done only when occlusion is perfect. There is no change in occlusion. If the occlusion is not perfect, you have to make a new denture. No relining or rebasing is done when the occlusion is not correct. If the occlusion is correct, only then you have to change the intaglio surface or the base of your denture. There is where you require relining. So relining is a smaller procedure. Mainly rebasing is the bigger procedure wherein you change the entire base. In the reline, we are just going to line the the intaglio surface with a thin layer of your liners. Very important question. If both maxilla and mandible have to be relined, a lot of time these questions have come up. Both maxilla and mandible have to be relined. You always do maxilla first. Why? Because that maintains the occlusal plane, right? So always maxilla first when you're doing relining and or rebasing. So when we talk about the major relining procedures, you have to understand that they can be divided into clinical procedures and lab procedures. Talking about clinical procedures, you have static relining methods, you have functional relining methods, and you have chair side relining methods. Static, you will have open or closed mouth. Functional will always be a closed mouth technique. In the lab, you do it with articulator method or a jig method and flask method. So these three techniques are lab procedures of relining or rebasing. Boucher. Boucher gave an open mouth technique. The functional technique was given by Winkler, right? What is a tissue conditioner? Talking about a tissue conditioner is a soft relining method material. They are basically used for intaglio surfaces, especially when your tissues are abused. You never reline your dentures, you never rebase your dentures if the tissues are abused. So, the first step in treatment of an abused tissue is to discontinue wearing the dentures. Once the tissue abuse has ended, the tissue looks firm and healthy, only then you should reline your dentures. Now, there have been questions like adjustments with the non anatomic we relined, you always do maxilla first. Why? Because that is a smaller procedure, mainly rebasing is the bigger procedure wherein you change the entire base. In the reline, we are just going to line the intaglio surface with a thin layer of your liners. Very important question. If both maxilla and mandible have to be relined, a lot of time these questions have come up. Both maxilla and mandible have to be relined. You always do maxilla first. Why? Because that maintains the occlusal plane, right? So always maxilla first when you're doing relining and or rebasing. So when we talk about the major relining procedures, you have to understand that they can be divided into clinical procedures and lab procedures. Talking about clinical procedures, you have static relining methods, you have functional relining methods, and you have chair side relining methods. Static, you will have open or closed mouth. Functional will always be a closed mouth technique. In the lab, you do it with articulator method or a jig method and flask method. So these three techniques are lab procedures of relining or rebasing. Boucher. Boucher gave an open mouth technique. The functional technique was given by Winkler, right? What is a tissue conditioner? Talking about a tissue conditioner is a soft relining method material. They are basically used for intaglio surfaces, especially when your tissues are abused. You never reline your dentures, you never rebase your dentures if the tissues are abused. So, the first step in treatment of an abused tissue is to discontinue wearing the dentures. Once the tissue abuse has ended, the tissue looks firm and healthy, only then you should reline your dentures. Now, there have been questions like stripping, stripping method. What do you mean by stripping method? Stripping method is done for non-anatomic teeth. Please do not get confused. Stripping is done for non-anatomic teeth. What is used? We use carborundum paste. Carborundum paste is used for stripping, right? So that is how you do the adjustments with the non-anatomic teeth. So what you need to know is that if the question is talking about stripping method, then the answer is going to be carborundum paste, right? How do you immerse your denture? Denture immersion, what is the best medium to immerse a denture? The best medium is chlorhexidine, diluted chlorhexidine. Other than that, sodium hypochlorite can also be used, right, for denture immersion. But mostly you will get a question wherein the answer is going to be chlorhexidine which is diluted. Coming on to another important topic, the immediate dentures. Understanding the immediate dentures, they are usually made when the anterior teeth cannot be left, right? You cannot allow the patient to be without teeth. So, what do you usually do? You first knock off all the posterior teeth, right? You do their extraction, and after that, record your bite, trial, everything is done. And then on the model, you remove the anterior teeth, right? Patient has got periodontal compromised dentition. You remove the posteriors first and do your bite and trial as if you're doing a removable partial denture. Place that into the articulator, remove all the anterior teeth which have been done in stone. Once you remove all the anterior teeth, what do you do next? You do your complete denture setup of teeth and acrylize it. Right? Once you acrylize it, the entire set is ready. On the day of extraction, as soon as you do the extraction, place the denture in the patient's mouth. Most important thing, this denture should not be removed for at least 48 hours. Why? Because that is the time, if the patient removes the denture, the entire extraction sockets are going to swell up. Once they swell up, the patient will not be able to fit in the denture. So, most commonly in the case of an immediate denture, the patient will come back to you and tell you after 3 days that the denture fitting has become really good and tight. Why? Because whatever slight amount of swelling was there, that has made a close contact between the tissue and the denture base, thereby rendering the denture more active and more retentive, right? So immediate dentures are basically indicated in these cases, but with an immediate denture, you will always need to fabricate a conventional final denture after the complete healing of the soft and hard tissue is completed, right? You get a lot of questions from overdentures. What do you mean by overdenture? An overdenture is a situation where you have a few teeth remaining in the mouth, plus these teeth are healthy periodontally. Right? They're strong teeth, mostly canines. Right? So you use canines on both the sides, and these canines are going to act as an overdenture abutment. So, what is going to be the advantage of using an overdenture? Retention, of course, but the primary importance would be proprioception, right? Because your abutment teeth, which are present, have got periodontal ligament, and this periodontal ligament is going to give you a very good proprioception. So, the main advantage is proprioception, and next is your retention. It helps in decreasing the bone resorption rate, right? So these are important uh, uses of your. So we are going to talk about a very important topic, maxillofacial prosthetics, and we get a couple of questions from obturators, knowing that an obturator is that prosthesis which is used to close any congenital or acquired defect of palate. Now, these obturators can be classified into different types, Number one is based on the phase of treatment, the most important classification. So you have your surgical obturators, you have your interim obturators, and the definitive or final obturators. So the surgical obturators can be either immediate surgical obturators or delayed surgical obturator, that is within 10 days, and immediate is on the same day of the surgery. Interim would be few weeks to months, but these are going to definitely be changed into a definitive final prosthesis. Now, you can also have this classified based on the area of restoration. So, there are palatal obturators and there are meatal obturators, right? So, these two are the most important of the classifications. So, what do you mean by a meatal obturator? Where it goes up to the nasal meatus, right? It establishes closure with the nose also, right? That those are called as meatal obturator. Next question comes in from palatal lift prosthesis. Now these are special obturators which have a posterior extension, right? There is a posterior extension to restore what is called as palatopharyngeal incompetence, right? So basically a palatal lift prosthesis is made to restore the palatopharyngeal incompetence by having a posterior extension. Then you also get questions from mandibular guide flange prosthesis. This is also called as a training denture or a training flange prosthesis. Now, these are used for mandibulectomy patients where you have loss of continuity, right? You have a discontinuous kind of mandibulectomy. So, the main purpose is to prevent the excess deviation of the remaining segments. As you can see, it is called as a guide flange. So this is going to guide the patient's mouth into position, right? So that is what a mandibular guide flange prosthesis is. What kind of materials are used? Basically HTV and RTV. So these HTV silicones are high temperature which need to be cured, and RTV silicones are room temperature, right? So these are the two materials most commonly used for your maxillofacial, the maxillofacial prosthesis. Implants is a very vast topic. You get a lot of questions nowadays from implant prosthodontics. So there are a few important things which we need to know here. Mainly what should be the minimum inter-implant distance. Minimum inter-implant distance should be 3 millimeters. What should be the minimum distance between a tooth and an implant? 1.5 millimeters is the minimum distance. What should be the minimum distance from sinus floor? 1 millimeter. What should be the minimum distance from inferior alveolar nerve canal? It's 2 millimeter. The minimum distance from mental foramen, very, very important. We need to understand that the mental foramen is going to have an anterior mental nerve loop. So when you have an anterior mental nerve loop, you should be at least 5 millimeters away, right? Then you have something to understand. The ideal dimensions of an implant should be 4 millimeter in diameter and 10 millimeters in length, right? So that is what is the most ideal dimensions to be placed in most of the sites. Then you have a concept on which you get questions, which is known as osseointegration, right? Osseointegration is a concept where the bone comes in contact with the implant directly, right? There is no periodontal ligament when we are talking about an implant. Right? So this is called as an osseointegration. The most commonly used alloy is Ti6 Al4V, titanium, aluminium, vanadium. This is the most commonly used alloy for manufacturing an implant. So, what is the time period required for osseointegration? Majorly in maxilla, we take it as 6 months. In mandible, the anterior has to be kept for 3 months undisturbed, and then a tooth can be loaded over it. And in posteriors, it is going to be 4 months, right? So, this is the minimum osseointegration period, what is required now. Other than this, you get questions from mandibular overdentures which are supported by an implant. So you have to understand a very basic simple diagram over here. Considering this as your mandible, and these are the locations of your mental foramina. So you need to divide the mental foramina into equal sections A, B, C, D, and E, right? So these are going to be the sections where you can place an implant. So as far as the mandibular anterior area is concerned, you can place your implants if you have to make a 2 implant overdenture, B and D position. When you want to make a 3 implant overdenture, it is commonly A, C, and E positions. Now, these implant overdentures can be either retained with a ball abutment, or that is called as an unsplinted overdenture abutment, or a bar retained overdenture, wherein the 2 implants will be joined with a bar, and over this the denture is going to be fabricated. So these are implant overdentures, majorly successful in mandible, not very successful with the maxilla. Coming on to the different components, you need to understand that when you see a diagram like this with threads, this is called as an implant fixture, right? Or this is the implant which goes inside the bone, which simulates the the root of a tooth. Over this, there is a small screw which is called as a cover screw, right? Which goes in here and seals the implant. Next to this is called as a second stage surgery, which is performed after the osseointegration period. In this, the cover screw is removed and the next component is attached, which is called as an healing abutment or a permucosal extension, PME. After you have done your healing abutment placement, 15 days the implant is left undisturbed. And after 15 days, you are required to make impression. So when you make an impression, there are two techniques of doing an implant impression. One is called as an open tray and the other one is a closed tray. So usually open tray is used when you have multiple implants placed, or an open tray is used when you have implants at varying angulations. Closed tray is commonly used for single implants or when you have parallelly placed implants. So once this impression is done, onto the impression coping, right, what we call as an impression coping or an impression post, you have to attach something which is called as an analog. So this analog is going to act as an implant where in the model, right? So this is going to act as an implant on the model, and then you start fabricating your final prosthesis. In this final prosthesis, there are two options. One is called as a cement retained prosthesis, and the other one is a screw retained prosthesis. Screw retained is preferred more because you can have retrievability in a screw retained prosthesis, whereas in a cement retained prosthesis, it is very difficult to cut and remove the entire crown or the prosthesis. Other than this, in implants, they do talk about, questions come up from bone grafts. So we need to understand that you have autogenous bone, you have your allografts, xenografts, and alloplasts. So do not confuse between allograft and alloplast. Autogenous is from the same body, right, from the same patient. Allograft is from the same species, right? I can get my demineralized or mineralized bone grafts coming in from different cadaveric sites, right? Different human beings. Xenografts are based on your animal grafts. Majorly, it is bovine origin for the grafts, and alloplasts are your synthetic bone substitutes. Right? So this is how you get a couple of questions on your bone grafts also when you talk about implants in your MCQs. What would be a good success rate, right? That is a question asked many a time. So 95% after 5 years is a good success rate when we talk about an implant which has been placed in the patient's mouth. Now, other than this part, we are going to talk a bit about a very important topic called as selective grinding. So once we have gone through my session on the balanced occlusion, which is available on the internet, you have to understand that you get questions from selective grinding, and we need to see that what kind of selective grinding has to be done in different cases. So when you have the working side, right? So when I talk about working side, the rule which applies is called as Bull rule. Bull rule is not applicable for non-working or centric or protrusive. It is applicable only for working side, which says that buccal cusp inner inclines of the upper teeth have to be trimmed when they are in contact, or the lingual cusp inner inclines of the lower teeth, right? So this is called as Bull rule. So when you have an interference on the working side, this is what you follow for your selective grinding. Non-working side is considered to be the most destructive interference. The reason why we call it as most destructive interference is that on the non-working side or the balancing side, the contacts are usually on the maxillary palatal cusps and mandibular buccal cusps. Both these cusps are our functional cusp areas, so we do not want to trim a lot of maxillary palatal and mandibular buccal. But if at all in a question you do not have an option, in that case, if you have to choose from either maxillary palatal or mandibular buccal, we would always be trimming the mandibular buccal, because the maxillary palatal, as I discussed earlier also, maintains the occlusal plane, right? That is why it is called as the primary supporting cusp or the primary functional cusp. Coming on to the most important part of this selective grinding is that we always deepen the fossa, right? You always deepen the fossa and never trim the cusp, right? So that is a very, very important part. Always check and never trim the cusp height. We prefer to deepen the fossa, because once you start trimming the cuspal height, the vertical dimension gets altered, thereby the centric cannot be maintained, right? So you get a lot of questions coming up from selective grinding part in your exams. So that is most of it. So in the last minute revision points from prosthodontics point of view, I will be giving up a small session more on the doubt questions, which are very common, which I've seen all throughout the year. So maybe a 15-20 minute session, so that finally you do not get confused between the answers which you have seen in the books and the answers which are going to be the correct answers to be marked, right? So all the best for your exams. So here we are going to talk about a few important points based on the different MCQs which have appeared in the past papers and are important, and the controversial parts of it. So number one is about the lateral pterygoid muscle. So you need to know that when the left lateral pterygoid contracts, mandible moves right, and when the right lateral pterygoid contracts, the mandible moves towards left, right? So that means the mandible will move towards the paralyzed side, right? You must remember this, very important. You get a lot of questions here, that what happens when the lateral pterygoid, the left lateral pterygoid is paralyzed. So whichever side is paralyzed, your mandible is going to move towards that. Shunting effect, a question asked a lot of times. Shunting effect in complete dentures. Now this is caused because of tipped occlusal plane, right? So that means if the occlusal plane is lower in the molar area, what is going to happen? The upper denture is going to displace posteriorly, and the lower denture is going to displace anteriorly, right? So that is what is called as shunting effect. A lot of times this question has been asked as doubts. Third thing is the difference between CID and IID. CID is the conventional immediate denture and IID is the interim immediate denture. In the interim immediate denture, all teeth are extracted on the day of denture insertion, right? And when you talk about CID is what we discussed in the immediate dentures. The posteriors are extracted first and then the anteriors on the day of denture insertion, right? So that is the difference between CID and IID, right? Coming on to the the resilient liners, you get questions from the resilient liners where you need to know that the silicone elastomers are more prone to fungus, right? Whereas the acrylics are good long term liners and you can reline it very easily with the acrylic part. The tissue conditioners are all short term, right? So the silicone elastomers and acrylic, which are plasticized acrylics, are long term reliners, and the tissue conditioners are short term reliners. Then you very commonly get a question, what should be the position of the incisal pin, right, in a semi-adjustable articulator? So the incisal pin is always out of contact. Why is it out of contact? So that it does not interfere with the condylar guidance setup. That is why the incisal pin is always out of contact. Shadow effect. What is shadow effect? Shadow effect is the negative space, right? What is the negative space? So when I'm talking, when I'm speaking, you can see some amount of space between the upper and lower incisors. That is called as negative space. It is different from the buccal corridor, so do not get confused. Then you get a question on emergency retentive force. Now, emergency retentive force for a denture is invariably, the answer is atmospheric pressure, and the value is 14.3 psi. But if you do not have atmospheric pressure in your options, the next best option is going to be base of tongue. If you do not have base of tongue also as an option, the next best answer is going to be posterior palatal seal area, right? What kind of teeth, right? When you have decreased interocclusal distance, right? When you have very low interocclusal distance, resin teeth, the acrylic resin teeth are contraindicated. Why? Because you will have to trim them a lot to seat them, to place them, and they lose their bulk. If the resin teeth do not have bulk, they are going to get fractured, right? That is why they are not used when you have decreased interocclusal distance. Talking about the posterior reference points, right? The most commonly used posterior reference point is the Guy's point. Now, what are the different points and what do they mean? So, Guy's point is 13 millimeters in front of the most upper part of external auditory meatus on the line which is passing to outer canthus, right? So this is the most important posterior reference point. Other than this, you have Bergstrom point, which is 10 millimeters anterior to the center of spherical insert for the external auditory meatus and 7 millimeters below the FH plane. The third most important point is the Bayron point, which is 13 millimeters anterior to the posterior margin of tragus on a line passing from center of tragus to the outer canthus, right? So these are the three most important posterior reference points which you will come across very commonly. The next important thing is that when you talk about a fluid wax technique, so if it contacts the tissue, it appears glossy. No contact, it appears dull. But with green stick, it is exactly opposite. Right? So that is what you need to see in the question. If the question is asking you about fluid wax, when it contacts the tissue, it becomes glossy. When it does not contact, it becomes dull. But green stick, when it contacts the tissue, it becomes dull. And when it does not contact, it becomes glossy. Right? So that is what you need to remember. Do not confuse between fluid wax in the question or green stick in the question. Then you have a dual function muscle, very commonly asked question. Masseter is the muscle with dual function, wherein the first function is elevation and protrusion. The second function is that when the mandible is protruded and biting force is applied, right? At that time, the deep portion of this muscle stabilizes the condyle, right? That is the important reason for your dual function of masseter. Now, coming on to a few small points in your FPDs, you need to understand that when you talk about the shade matching part in the Vita shade guide, they are always arranged by value, right? The hue comes in the end. The sequence for hue is going to be A, B, C, and D. Wherein A is the red yellow hue, B is yellow, C is gray, and D is red, yellow, gray. Right? So you must remember the hue sequence, but the shade is matched with starting with value, right? So it starts with B1, A1, B2, and the last goes as A4, C4. Read this entire sequence because it is important when it comes in your exam. PKT instruments, they are given by Peter K. Thomas. All these instruments are used for making wax pattern, wherein the PKT 1 and 2 are the wax addition instruments. PKT 3 is the burnisher, and PKT 4 and 5 are your wax carvers, right? Do not get confused between the different PKTs. In RPD, you need to know the color coding for your RPD designing, right? This is a very important part. So the brown color is the metallic component of the RPD. Blue is for acrylic. Red is for rests or mouth preparation, and black is for the survey lines, right? So this is how you design your removable partial denture. What is meant by heel raising movement? So heel raising movement is basically when the posterior segment of a distal extension RPD raises on force application, right? So this basically means an antero-posterior rotation which is away from the tissues, right? So this is the important part which we need to understand. A few important relevant uh, questions which come up, and there are a lot of doubts because these you have answers in different books given in different some are correct, some are the old edition answers which have now changed. So this was most of the important points which I wanted to convey. So with this, we end the LMRP session, and all the best for your exams. So we are going to talk about the important points in the last minute revision points for fixed partial dentures. Now, it is important to understand as to what is a fixed partial denture, right? So you have a tooth, a missing space, and another anterior tooth. And when you give a fixed prosthesis, this is how the entire prosthesis is going to be. And what you see here is the teeth which are giving support are called as abutments. This part which covers the abutment is called as a retainer, and the one which replaces the missing tooth is called as a pontic, and the joint what you see between the pontic and the retainer is a very important component called as connector, right? So these are the different components of a removable partial for a fixed partial denture. Abutment is not a part of fixed partial denture, right? Abutment is that part which is giving support to the fixed partial denture, right? Now, the first part, as we know, is diagnosis and treatment planning. So, when you do the diagnosis, there are a few things which you want to know. You want to know the history of diabetes. Why? Because this is directly related to periodontal disease. A diabetic patient might develop periodontal disease. Taking that into consideration, we are going to plan the type of fixed partial denture we want to give to such a patient. Xerostomia, you definitely want to know about this because this is decrease in the amount of saliva, thereby increasing caries, right? So this is a very important point here. What do I examine? Intraoral examination. What do I examine? First thing is the mouth opening. What kind of questions come in mouth opening? What is the average? It is greater than 50 millimeters. What is the restricted mouth opening? Somewhere around 35 millimeters. And what is acute closed lock? That is around 25 millimeters. So we need to know these values when we do the intraoral examination for the patient, right? There is something which is called as a negative space. Negative space is that part which you can see, like when I'm talking, what you can see is the space between the upper and lower incisors when in function. So that is what is called as a negative space. What do you do in the gingival examination? Anyways, that is going to be covered in detail when you read about the subject of periodontics. So in gingival examination, we need to understand that there is a procedure which is called as walking the probe, which is used. And when you evaluate the gingiva around the abutment tooth, the maximum angulation which is possible for the probe is 10 degrees, not more than 10 degrees. The probe cannot be tilted more than 10 degrees when you're doing a gingival examination. There is something which is called as CAL, which is the clinical attachment level of the periodontium, right? This is the gold standard. So CAL is basically recession plus the probing depth. Why do we want to know about this CAL? Because this is what is going to determine the crown root ratio for an abutment tooth. So this crown root ratio has to be checked. That is the reason why we want to know the periodontal status, if the root will be able to provide support or will not be able to provide support to the fixed partial denture which it is bearing. That is the reason we need to know the clinical attachment level. Next important examination is called as fremitus. We know how to check for fremitus. So if you have excess tooth movement when the patient is biting, you understand that the patient is a patient of fremitus and you will have to alter your procedure accordingly. Vitality testing, very important. If the question asks which is the best way of vitality testing, the answer is test cavity. Cold test, heat test, electric pulp test, all these tests will have some false positives or negatives. Test cavity is going to be the best way when we talk about this. Diagnostic mounting, a term which you have heard so many times. What is diagnostic mounting? Why do I want it? The primary reason for a diagnostic mounting is to check from the lingual view the occlusion, right? To check occlusion lingually from the inside, the only way is to do a diagnostic mounting. Now, what you need to understand, is a specific classification of the residual ridge which was given by Siebert. This question has come up many times. Class 1, class 2, class 3. Class 1 means loss of width. Class 2 means loss of height. And class 3 is the combination of 1 and 2 where you have loss of width and height, right? So you need to know that. Another important part in FPD is to understand that if you have to give both RPD and FPD, which should be given first? FPD should be given first and then RPD can be accordingly adjusted, right? So this is very important. This question has also come up a couple of times. Now talking about the different parts. So first we are going to discuss about what are retainers, what are different types of retainers. So you have two types of retainers. One are major and the other one is minor. So when you talk about minor, you have inlays and onlays, which are your minor retainers, and the major retainers are full veneer crowns and partial veneer crowns, right? So these are your major classification for retainers. Another classification of retainers is based on the materials. So you have all metal, you have metal ceramic, you have metal and acrylic restorations, you have all acrylic restorations, you have all ceramic restorations, right? So these are different types of classification based on the materials, right? We are going to discuss these in greater details eventually. Now the first most important topic in relation to FPD is the Pontics, right? So how do you work on Pontics? What are the type of questions? What are the classifications? we need to understand. So you have to know the parts. The gingival surface of a pontic is never concave, right? Always remember that the gingival surface is never concave. Another question which comes in gingival surface is that it must be highly polished, right? So these are two important points of the gingival surface. Occlusal surface. Size of the occlusal surface should always be less as compared to the natural tooth. The pontic's occlusal surface dimensions buccolingually have to be shorter than the normal ones, right? Then you have your proximal surfaces designed to give you self cleansing activity, right? These are the important questions which come up from that. Talking about the basic classification of pontics, now you can divide them into a class of mucosal contact, right? So they can be with mucosal contact or without mucosal contact, like hygienic pontic, also called as sanitary pontic. With mucosal contact, you have saddle, you have ridge lap pontic, modified ridge lap pontic, and ovate pontics. The other classification is based on the materials which we have used. It can be a PFM, it can be acrylic, fused to metal, it can be all metal. We have just discussed all those things. And the method of fabrication. Now, these can be devised into different ways. It can be a custom made pontic, it can be a prefabricated or a combination of a prefabricated and customized pontic. Right? So these are the major classifications of a pontic which we need to know. Now the important questions which come up from pontics are: what pontic is to be used in which area, what is the special feature of that pontic. That is what we are going to discuss. So saddle, right, it overlaps both the buccal and the lingual part of the ridge. The problem, the disadvantage is hygiene. How does a saddle pontic look? This is the ridge. A saddle pontic is going to be somewhat like this, right? So what do you mean? It is going to cover the buccal as well as the lingual part. But when you talk about a ridge lap, a ridge lap is almost same. But what has been done in a modified ridge lap? In a modified ridge lap, the situation is something like this. So you have the entire pontic, but there is no contact in the lingual side. This area is free for maintaining hygiene. That is why a modified ridge lap is one of the most common made choices for replacement in pontic sites. The next important one is called as an ovate pontic. The ovate pontic is used in areas where after extraction the healing is incomplete. So when the healing is incomplete, or it is used in cases where you have defective residual ridge. So when you have defective residual ridge, the ovate pontics are used. How do you see an ovate pontic? This is how the situation is immediately after extraction, and the ovate pontic comes from within. This is how an ovate pontic looks like, right? Similar to this is a conical pontic, also called as a bullet pontic, wherein this is the ridge and the bullet pontic is going to be like a cone here, right? This is what is called as the bullet pontic. What is the problem? The problem with a bullet pontic is wide embrasures, right? The only major disadvantage is wide embrasures. That is why you use it only in the mandibular posterior segments, right? The next is your sanitary pontic, also called as hygienic pontic. This pontic has zero tissue contact. So there is absolutely no tissue contact in sanitary or hygienic pontic. Minimum size of the pontic should be around 4 millimeters, and minimum distance from the tissue to the pontic should be 2 millimeters. Some textbooks also mention it as 3 millimeters, but 2 millimeters is what you can take, because 2 millimeters is the space which is required when you want to clean this area. That is the purpose of giving a hygienic pontic. Now, these hygienic pontics are of three types. One is called as a bar sanitary pontic. The other one is called as a conventional or fish belly pontic. And the third one is called as a modified sanitary, or so known as Perel pontic. Now, what is the difference? When you talk about a bar pontic, your pontic's under surface is going to be like a bar, right? This is called as bar pontic. So when you talk about a conventional or a fish belly pontic, it is going to be something like this. This is called as a fish belly, and the third one is your Perel pontic, wherein the surface is concave. This is your modified sanitary or Perel pontic. So this is called as most commonly used one is the fish belly pontic. You have to remember that when you read your most common book of prosthodontics, Deepak Nallaswamy, the diagrams there are confusing. They have confused by putting fish belly into a different category and showing the diagram wrongly. So that is what you need to remember when you read your text. So these are the different types of pontics. Coming down to the next part, which is called as a connector. Now, what is a connector? A connector connects the pontic to the retainer. So what are the different types of connectors? You have rigid connectors and you have non-rigid connectors. So these rigid connectors are used when you have to use, most commonly, they are the ones which are used most commonly because they transmit the entire force onto the abutments. They are called as the rigid connectors. Non-rigid do not transmit the entire force to the connector, to the abutment. They are the loop connectors. You have split pontics used for tilted teeth. You have something which is called as a cross pin and wing connector, and a tenon mortise prefabricated connectors, right? So these are the different types of connectors which are available, which can be made using the, they can be casted, and some of them are available as prefabricated pontics. They can be used in cases where they're required. We are anyways going to discuss about that in detail. So when you talk about a tenon mortise connector, a tenon mortise connector has got a male component and has a female component. So when you have a tooth here, this is going to be the pontic and the another retainer. So this pontic is going to have a connection, something like this, which is going into this part of the abutment tooth. So this is a non-rigid connector called as a tenon mortise connector. The loop connector, where do you use it? The question is very peculiar when you talk about loop connectors. Where do you use a loop connector? A loop connector is used in cases of diastema, right? When you have diastema, this is one incisor, you have another incisor. The loop connector is going to go in like this, right? When you want to maintain diastema, you want to show the patient wants diastema. These are the connectors which go into the palatal area. This is how you form the loop connector. The third one is a split pontic, which is commonly used in cases of pier abutment. What is a pier abutment? Pier abutment is an abutment which has got edentulous space anterior as well as posterior to it, right? So that is what is called as a pier abutment. Coming on to the basic design of a fixed partial denture. So what are the different considerations when you design? So the first one is length of the edentulous span. Now you have to understand that flexion, right? The flexion is equal to the length of the span by the occlusogingival height, right? And the cube of this. So that is how it is proportional. So a 2 pontic span is going to flex 8 times. A 3 pontic span is going to flex 27 times. So you can understand that if the number of pontics increase, if the length of edentulous span increases, you are going to have a lot of flexion in your partial denture. That is the reason when you have your zirconia bridges, long span zirconia bridges, the patient bites on them and they fracture because of that flexion. The zirconia will not allow, that material is a glass material, it is a brittle material, it is not going to allow any kind of flexion and it will give way just by getting it fractured. Right, so this is, we have discussed 2 points. One is the length of the span, second is the occlusogingival height, third is the arch curvature, and fourth is the direction of forces. Right, so we have to understand all these factors before we proceed and finalize the design of a fixed partial denture. Cases like these, where you have 5, 6, 7 to be replaced here, this is a linear arch, right? The arch is linear. But when you have to replace 1, 2, 3, a situation where you have a canine involved, you can see that the arch is turning. So when the arch is turning, the force application is more. So it is not a linear force application. So the concepts totally change when you have different abutments in different locations, right? Depending upon the curvature of the arch. Now, what is the criteria for abutment selection? Very frequently asked questions out of abutment selection, which we are going to talk about. The first is a root configuration. Increase in the buccolingual width of a root is always better. The abutment which has got increased buccolingual width is a better abutment. Longer root is better. Roots with curvatures are better, right? So root configuration helps you in deciding the abutments. Another important part is the crown root ratio, right? The optimum crown root ratio is 1:1.5. The minimum crown root ratio is 1:1, and the ideal crown root ratio is 1:2. That is why you need to know the periodontal status of your teeth, because if the crown root ratio is less than 1:1, that tooth cannot be used to act as an abutment to provide support for your fixed partial denture. The third important part is the bone support. So where you have healthy bone, the abutment cell can be selected. But when you have periodontal disease, the abutments cannot be used when you have periodontal defects. The fourth point all of you already know is the Ante's law. What is meant by Ante's law? This says that the total amount of pericemmental area of the abutments should be greater than or equal to the pontex, right? So they are talking about the root surface area of abutment should be greater than or equal to pontex. Now, who gave Ante's law? Ante's law was given by Irwin Ante, or it was given by Johnston. So the answer here is that it was given by Johnston. Ante just popularized it. The law was not made by Ante. So this law was made by Johnston. It was just that the Irwin Ante, he popularized this concept of Ante's law. Now, what are the different cases what you need to handle? Now, supposedly we are talking about a maxillary canine which is missing, right? So when you go through the detailed lecture, we have discussed it with a lot of examples, each and every different case which can come in your exam. But how do you understand that? That is what I am going to touch here now. So when we talk about a missing maxillary canine, so can I use a lateral incisor and first premolar to replace it? The answer is no. I would require a central incisor, a lateral incisor, and a first premolar to replace a missing canine. Why? Because number one, this is out of arch. The canine is always out of arch, right? So we discussed that arch curvature is an important point. Secondly, when you see the mesial abutment, which is the lateral incisor, this is the weakest tooth in maxillary arch. So you cannot rely on the weakest tooth in the maxillary arch. That is why lateral incisor alone cannot be used as a mesial abutment for your missing canine. First premolar can definitely be used because first premolar has got two roots. So you do not need an additional support posterior to the first molar. You need support in the anterior area. That is why you use a central incisor. Now when you talk about special cases, right? When you talk about special cases like tilted molars, what do you do in a tilted molar? If the question is asking what is the best way to treat a tilted molar, when the question asks best, the answer is always going to be orthodontic uprighting. Without fail, please do not commit a mistake here. When they are asking which is the best way, the answer is orthodontic uprighting. Otherwise, you have telescopic prosthesis and also something which is called as a mesial half crown, right? So we have to talk about that also. Telescopic prosthesis and mesial half crown. Now, what do you do when you have the opposing tooth which is supra erupted. In an opposing tooth which is supra erupted, if that level is 1.5 to 2 millimeters, you can try and do enamelloplasty. But if it crosses beyond 2 millimeters, we will definitely have to either orthodontically intrude it or do an intentional root canal treatment. These are the clinical options which you have. What do you do? There is a question coming on to this. What do you do when you have extensively damaged abutments? So when you have extensively damaged abutments, I have two choices. One, I can modify the restoration, and the other one is I can do a post and core treatment. Right? We're going to talk about post and core in a while from now. So you can do a modify restoration. How do you modify the restorations? By giving boxes, grooves, and pins. Right? These are the things which you use to modify your restorations. Talking about post and core, also called as dowel and core. Now, post is that part which goes inside the root canal, and core is where it is prepared to receive the crown. Right? So basically, what I require is a core, but what is going to give support to the core is the post which goes inside the root canal. It is going to engage that area and provide you a pillar of support for your coronal restoration, right? So for post and core, you have 6 important features which you must remember when you are talking about post and core. Number 1 is adequate apical seal. Right? How much of that seal is required? 3 to 5 millimeters, or 1/3 to 1/4 of the total root canal space. Number 2 is your minimum canal enlargement. You do not enlarge the canal too much because I want a good amount of remaining dentine thickness. Post length. What should be the ideal post length, right? So you are going to go apical and leave that 3 to 5 millimeters of the apical seal. So 2/3 of the root canal should be the minimum post length what you have. A positive horizontal stop. This is going to decrease the wedging. A vertical wall, also called as an anti-rotational groove. Right? This is going to be, if this is the cross section, you are going to have a small anti-rotational groove. This is usually used for custom made posts, right? Because this additional part, this anti-rotational feature, is not going to allow the post to rotate inside the canal. And sixth and the most important concept is extension of margin to sound tooth structure. Always. What is this? This is what we want to understand as ferrule effect. So when you talk about a ferrule effect, what you need to understand is that if this is my root, this is my gum level, what am I going to do? I have absolutely no part of the tooth which is exposed. So I'm going to do some crown lengthening, bring it down to here, right? Now this part of the tooth which is now exposed on both the side, I mean you can see it two-dimensionally here, three-dimensionally it is all around. This is what is called as a ferrule. That part of sound tooth structure which you want, right? This is a sound tooth structure. When I finally make a crown and seat it, what I want is that my margins of the crown should come and seat on the sound tooth structure. That is what is called as a ferrule effect. To do this, I am doing a procedure which is called as crown lengthening. What is meant by crown lengthening? You are trying to remove the gingiva, or you are trying to sometimes remove the excess bone so that the gums can be taken down so that you achieve that space for your ferrule. Now, crown lengthening is enemy of your crown root ratio. The more you do the crown lengthening, the smaller your root is going to become. So it is very important that you evaluate that once I do my crown lengthening, will I have enough amount of root to hold on to that crown to act as an abutment. Only then you proceed and do your crown lengthening procedure. So the advantage of a crown lengthening procedure is that you can create a ferrule. But the disadvantage is that you alter the crown root ratio, right? Another important question coming up from post and core is that any tooth which has post and core cannot bear lateral loads. They cannot bear any kind of lateral loads. Another common complication is the vertical fracture, and the most important question is the main symptom of this vertical fracture is pain on biting. When the patient complains of pain on biting, that means that the post and core treated tooth has now fractured, and that has to be taken care of. Talking about the basic principles of tooth preparation, right? When you talk about the basic principles, you have two categories. One is by Rosenstiel, one is by Schellenberg. And Rosenstiel said you have biological principles, mechanical principles, aesthetic principles. Schellenberg gave 5 different principles: preservation of tooth structure, retention and resistance, structural durability, marginal integrity, and preservation of periodontium, right? So these were the different principles given by Rosenstiel and Schellenberg. I'm not going to talk about all these principles in detail, only important questions. Taper. Less the taper, more the retention. Very, very important. What is an ideal taper? 1000 times this question has come. 6 degrees is the ideal taper, which means 3 degree per wall. What is going to be most retentive? Is it 6 degrees? No, 0 degree, also called as parallel walls. This is going to be most retentive. What is the clinically achievable taper? The clinically achievable taper is 15 to 19 degrees. What is the minimum taper required to locate an undercut? You want to see whether you have an undercut or not, is a minimum of 12 degrees. All these values will be asked very straightforward. These are all straightforward questions, direct questions, right? Next thing in principles is the term you have heard about margins and you have heard about finish lines. Are both of them same? Margins and finish lines? No. When you talk about margins, there are three types of margins: supragingival, equigingival, and subgingival margins. Right? Supragingival placed on enamel. Subgingival is placed on cementum. Supragingival, easily impressed. Impressed does not mean it impresses somebody. Impressed means you can easily make an impression of a supragingival margin. Subgingival, difficult impression. Supragingival, easy to clean. Subgingival, difficult to clean. Right? What is the advantage of a subgingival margin? What is the advantage? Beautiful aesthetics. The aesthetics which you get by this subgingival margin is the reason why we use a subgingival finish line or a subgingival margin. Now coming down to another important part, the finish lines. A lot of questions on finish lines. You've heard about chamfers, shoulders, heavy chamfers, radial shoulders, shoulder with bevel. What is the concept behind it? The first thing you need to understand is the concept of a shoulder and a chamfer. Shoulder is 90 degrees, chamfer is greater than 90 degrees. The width of a shoulder, right? The diameter of a shoulder is 0.75 to 1.25 millimeters. Diameter of a chamfer is 0.5 to 0.75 millimeters, right? So you need to understand that a shoulder and a chamfer are different not only in the terms of angles but also in the terms of width. What do you mean by a heavy chamfer? Heavy chamfer means it is a chamfer greater than 90 degree, but it is heavy. What do you mean by heavy? That it is almost around 1 millimeter to 1.25 millimeter. So that is called as a heavy chamfer. Similar term called as sloped shoulder. That means it is a shoulder 0.75 to 1.25, but it is sloped. That means the angle is greater than 90 degrees, which basically means that the sloped shoulder and heavy chamfer are both almost same. Where do I give a shoulder? Where do I give a chamfer? Supposedly, what you see here is a cross section of a central incisor. The labial part I require to be shoulder, and the palatal part I want it to be a chamfer, right? Because this is going to be in metal and this is going to be porcelain fused to metal. So this is called as shoulder in the labial, chamfer in the palatal. But can you see this junction at angles? This kind of a preparation is called as wing preparation. What if this is my incisor and I make a shoulder and gradually taper it to bring it to a chamfer? I can do that. Gradually taper it and bring it to a chamfer. This preparation will be called as wingless preparation. Wing preparation and a wingless preparation. What if I make a shoulder all around, even in the palatal side, complete shoulder? This is going to be called as radial shoulder. Radial shoulder means it is going to be shoulder all around, even in the palatal side or the lingual side. That is what is called as a radial shoulder. Now, what is a shoulder with bevel? If this is your tooth, you prepared it like this. This is your shoulder margin, and you create a small bevel here, right? This is what is called as shoulder with bevel. A bevel will always help in increasing the bulk of material at the margin, will always help in removing the unsupported enamel rods. So that is going to be an advantage of using a shoulder with bevel. Important concepts. The alveolar bone crest. When you do this preparation, the alveolar bone crest should be at least 3 mm away from your finish line. Alveolar bone crest should be at least 3 millimeters away. Second important thing is that when you see a tooth labially, right, this is how your tooth is. When you see the same tooth proximally, this is how the tooth is. That means that the labial and lingual CEJ and proximal CEJ are at different levels. The heights are different. So your finish line should always follow the contour of CEJ. Only when it follows the contour of CEJ, your entire finish line is going to be correctly placed in different planes, right? So this is about your finish lines. So if the question comes up as to which is the best finish line, now this question does not ask me whether they are wanting to do a metal crown, they want to do an acrylic, a ceramic, a PFM, we don't know. But the question is best finish line. So if the question is best finished line, the answer is always going to be knife edged finish line, a conservative finish line, knife edge or a feather edge. Why? Because this is going to be most conservative, right? So that is the reason these are in the category of the best finish line.